So I have already last. Again, I just quick. I'm Dr. IPS coach and endocrinologist based in Apollo Hospital, Indraprastha Apollo Hospital. So last time we had discussed about thyroid disorder one. There was basically hypothyroidism and subclinical hypothyroidism. And today we will be talking more about hyperthyroidism and nodule, thyroid nodule. So we'll try to cover up this. So that's why we divide in two parts: thyroid disorder one and part one and part two. So so today will be the second part, and just quickly going through that same two slides which I showed you last time. The thyroid gland is a very a gland which is situated in the interior part of the neck. It has got two lobes, the right lobe, the left lobe joined by an isthmus. A very good vascular supply, so anatomically in a very good position and having a very good vascular supply, and carrying on all the metabolic functions of the body. So further on, and it's basically if you see the physiology part of it, there's a axis between the hypothalamus pituitary thyroid axis. This is one of those endocrine system which has a very good feedback mechanism. So the hypothalamus is producing thyrotropin releasing hormone, which goes and acts on the anterior pituitary, which causes a release of TSH, thyroid stimulating hormone, which goes and acts on the thyroid gland and producing thyroid hormone T4 and T3. So that's how it's working. Now, that what is basically happening is when you have an excess of T43 in the body, it goes and inhibits and acts on the axis again in the pituitary area and the hypothalamus, so inhibiting TRH, inhibiting TSH. So you don't have less production of TSH, right? So less thyroxine production. So just a very good feedback mechanism to make you understand this. So that's how it goes. So if you have excessive thyroid in the body, there will be inhibition of the by TSH and TRH. So less T4 and T3 production by the gland. So that's how it works. And now coming on to basically, I talked about this last time, the same slide, thyroid disorder in children, primary hypothyroidism, secondary hypothyroidism, primary hypothyroidism. Now we're going to talk more about hypothyroid and thyroid nodule. So primary hypothyroidism mainly can be autoimmune Graves' disease. It could be neonatal Graves' disease. There's a transplacental passage of TSH receptor stimulating antibody from the mother to the baby, resulting in neonatal thyroid Graves' disease. It could be fictitious ingestion of excess thyroid hormone by mistake. Many times, mothers and fathers they leave their bottles down, and the child just opens it and starts taking it. So he likes it, he takes more tablets. So that's fictitious. Then secondary hypothyroidism, that means there is excess production of TS excess, so the hypothyroidropinemia. Now, other which is thyroid nodule, it may be benign, it may be malignant, so that depends. So then there's TBD deficiency or excess, synthetic defects, hormone and keratin. So we'll not talk about TB deficiency and synthetic defect. Otherwise, we'll have to have part three. So we'll focus on mainly, there are two mainly things, hypothyroid and thyroid nodule. Now, the so let's start with a case. A 9-year-old child, as having one or two history of goiter, no symptoms, but noted enlargement on the right side for 1 year. So there was no symptom, but there is noted enlargement of the right side for 1 year. Physical examination, 3 into 4 side right-sided thyroid mass, firm, adherent to the soft tissue. So you find it very dangerous. The thyroid function tests are normal. So how will you less do clarity? You want to find out this nodule is it is cystic or it is solid, or what is a little bit about the knowledge of the clarity of nodule. So what do? You do a scintigraphy, you do an ultrasonography, you do an FNSC, etc. So any patient, a physician or a pediatrician or anyone who comes across a nodule, so you will do some basic things. You will like to do a scintigraph ultrasound, you do a set of FNSC, you do a theorem therapy. So basically, I think the best answer would be the ultrasonography. You do an ultrasonic to find out the clarity of the nature of the nodule. We're not talking about the what is a nodule. Is it a malignant or benign or this thing or it's difficult? But initially you have something about where cystic or it's whether colloid or whether it is solid. So basically the answer would be ultrasound. Okay, so ultrasonography will be the thing to be done, and then coming on to another case, a 13-year-old female child, 2 months, with history of fatigue, 2 month history of fatigue, nervousness, getting tremors in the body, and feeling very hot, and eating a lot of food and still losing weight. So eating more, polyphagia and weight loss, polyphagia various complaint. Her scholastic work decline in quality. She is not able to perform the same amount of schoolwork and other things she was doing, which she was doing before. So the parents are complaining, her teachers are complaining she's getting low. His cholesterol was becoming bad. She suddenly they noticed that there she had some enlargement on the neck, and the eyes were getting a little prominent. On a physical exam, BP was normal 130 by 60, slightly raised of systolic. The pulse was normal 96 to per minute. Warm skin, eyelid retraction, and there was and tremors and mild muscle weakness. So the TSH is zero point zero 0.02 units, T3 T4 are high. So what do you do in this case now? So you have a patient, a girl whose TSH is low, T3 T are high. So what will you do? Start with antithyroid, or will you do a PET scan, or will you do an ultrasound FNAC, or you do a thyroid scan? So the worst thing what one must do is a thyroid scan. This is different from ultrasound. So you're going to do a thyroid scan, whether you do a iodine 131 or now people are more perfectly do 99 integration scan. So when we do a scan, why we're doing a scan before starting any treatment is we want to find out whether this is thyroiditis, what is the cause of this symptom this girl is having, and what is the cause of the swelling. So when we do this thing in these patients, what we find is that when the thyroid scan is done with technetium item, if there's a diffuse uptake, there's a diffuse uptake. Can you see here that appreciate this? There's a diffuse uptake here. That means this is more likely to be a grave disease. So there's an uptake completely in the area of the whole thyroid gland. And then if there's focal increase in uptake. So do you have focal means that in some area there is one. So here you can see here, this is here you can see here there is focal uptake. So this is most probably an adenoma, functional adenoma in the gland which is causing excess production there only. Or there may be a area where there's uptake and where there's no uptake. You can see here there's a cold nodule and there is good uptake. So here there's a toxic multinodular. So there are hot areas where there's a good uptake and cold areas where there's no uptake. So you have this is called as a multinodular, toxic multinodular water. So you have all these findings, and here you can see where there's a patchy decreased uptake, CLT or subacute thyroiditis. So there's a very low uptake. So this is a case of thyroiditis, low uptake is chronic lymphocytic thyroiditis or subacute thyroiditis. So these are things one has to keep in mind while doing this. This as far as this is concerned. So whether it's it's an autoimmune nodule, or whether it's a not a hot nodule, or whether it's a cold nodule, or whether it's grave disease. So that's the advantage of doing a technetium scan, because there are many patients who are being wrongly treated as grave disease because they actually have thyroiditis. So in thyroid, you have the same picture. You have high T4, high T3, high low TSH. But when you do a scan, you find there's no uptake at all. So that uptake is not there because it's thyroiditis. And if there's good uptake, it's grave disease. So that's good way of differentiating them. So I think everybody must understand what I'm trying to say. So let's come to another case. This is a boy of 13 years male who presented with complaint of progressive weight loss. So they come to you that there's progressive weight loss. So you start thinking, does he have diabetes? Oh, because of diabetes, he's losing weight. Or he has some other problem, or he's having some nutritional issues. So one starts it. So when the history taken, they say that he has heat intolerance. He has a poor concentration span. He loses his concentration very fast. पढ़ते छोड़ देता है पढ़ना. So he starts looking at here, looking there, looking. Swelling in the neck is seen, as you can see, a very nice swelling in the neck is there, and there is no history of polyuria. So diabetes is tried to be excluded. There is no history of excessive sweating. So why you asking about excessive sweating? Because there are some conditions where there's sympathetic overproduction, and they may have excessive sweating. And then tremors. There was no history of any tremor. This is a part of the hyperthyroid picture. Family history was there. The mother was diagnosed hyperthyroid in pregnancy. So she required short-term thyroxine. So she took thyroxine for a very short term in pregnancy. Later it was stopped and she did not need thyroxine. So this is, this. So going through that, let us see this boy a little more better. We find that his height is 171 centimeter, is quite tall, above the 96th percentile. His weight is 45.5 kgs. This is wrongly written centimeters. It should be kgs, and 50th centile. So basically, what we find here is that this child is having less weight for his height. So that means something is happening, which metabolic increase is there, and he's losing weight. Height is okay. Then blood pressure is 120 by 60 is fine. Respiratory pulse rate is around 140. It's quite high. Tachycardia, sinus tachycardia. So therefore, the pulse is high. His he's having tremor of the hand and tongue. This is the one. We've just closed his mouth that we can't see him. So trigger is SMR. SMR means sexual maturating rate. This is a rate where you see the pubertal status of the boy or girl. In cases of girl, it is breast development, axillary hair, pubic hair, and menarche. Wherein in boys, it is basically the penile length or penile, penile, or what you can development of the penile genitalia, and then you look at the axillary hair, and then you look at the pubic hair, and then you see the testicular volume. So these are different in the boys and this single. So in his case, what we found was he had a good penile length G4. So that means the genitalia was around 4. It's normally is 1, 2, 3, 4, 5. So therefore it was 4. His pubic hair was well developed. His axillary hair was well done. He had a testicular volume of 20 ml. So 20 ml each testis. So this tells us that this boy is going into puberty. He's already in puberty. So the local, when we saw the local examination, there was a soft, diffuse, fleshy, palpable, third palpable, which is also visible, and skin was very soft over the area. So his third function tests were done. And the third function test, when it was done, it was found that FT3 is 10.9, which was high. His FT4 is 4.9, which is high, and TSH is very low, less than zero point 0.0 micron. So TSH receptor antibodies, the trap. This is the receptor antibody that gives a good idea of what's happening in the antibody production. So this is used for mainly for hyperthyroidism, Graves' disease, and you can know from that. So it is very strong. It is positive, greater than 40. So thyroid scan done, you can see here, and this what you find here is a diffuse uptake of the isotope. So here you can see a diffuse uptake. So this is showing that this is a case of hyperthyroidism, Graves' disease. So here you have a Graves' disease patient. So this is a very it's very easy to pick it up and diagnose and follow the path. So then next question comes, what to do with this patient? So what you need to do is you have to start medical management or radio radiation or surgery. There are three options: either medical management, or you can go for radiotherapy, or you can go for third is you can go for as far as surgery. Surgery is very rarely done in the pediatric and adolescent population because you hardly find any such big masses which is causing obstruction to the trachea or obstruction to the esophagus and causing dysphagia or causing respiratory difficulty. So then that is there. So the drugs which are normally used in medical therapy are thyroid derivatives, PT or MMI. MMI means methylmethazole, and this is thyroid TOU. So basically, and carbimazole. These are some drugs which are being used. And so this is PETU is thyroid, and these are initial choice. Although radioiodine is picking up, increasing. Why? Especially in non-compliant patients who are not taking medicine properly, they're not getting into remission. So their surgery, radiotherapy is better option. And children who are mentally retarded, they are having radioreactions. In children who are about to go from home, getting into college, so those about to leave home are getting this. There you need to put them on this treatment, PTO MMI. Now PTO, MMI, and carbimazole is converted to MMI. These are converted. They have the anti-thyroid effect. How do they work? They inhibit the organification of iodine and the coupling of iodine tyrosine, the residues of the thyroid globulin molecule. So they inhibit the organification of iodine and the coupling of iodotyrosine residue on the thyroid molecule to generate T3 and T4. So one is the inhibiting organification of iodine and the coupling of iodine residues on the thyroid molecule to generate T3 and T4. So you will not have thioxin production. You're not going to have T3. T3 acts on the tissue level, T4 also there. So nothing is being produced. Obviously, that means the blood will become less. So when the blood will become less, symptoms also become less. So and the only thing is that when you use methimethone, the more it is more, the resolution of hypothyroidism is faster, and the rate of the side effects is dose related. So you start with a distal dose MMI of 0.5 milligram per kg, given once or twice daily, and then PTO is 5 milligram per kg thrice a day given time. So that is there. So because of the relationship between the dose of MMI and the side effects, the smaller the effective dose is necessary to control the hypothyroidism should be chosen. So one should always start from lower dose, maybe by 0.5 building up a kg, and then gradually increase if you're not getting improvement in your thyroid function test. So that is there. And normally we say that when the receptor antibodies start becoming lesser, so we say that there is time when you can think of that the patient is going into remission or patient is becoming better. So that is there. So basically, it has to begin for a longer term. The medicine sometime 2 years, sometimes the patient go into remission and they relapse again. They come back with you with hypothyroid symptom again, and then you give them another course. So that is why, and then there's such type patient who have more than 2 3 relapses and all, then we start thinking of using radiotherapy in them. So that is one that was case of. Now coming to another case, this is an 11-year-old. This is a known case of bronchial asthma. He's admitted with acute exaggeration. Respiratory rate is his pulse rate is 132 per minute, so very high. Tachycardia is there. Respiratory 36, so there is tachypnea also. There's central cyanosis. Tremor is there. There are no eye signs. Hyperdose, excessive sweating. Wheezes on chest. Auscultation is bilateral wheezes present. Is managed by bronchodilators methylprednisolone. FT3 is 3.13, FT4 is 1 TSH per. So you can see here there's a low TSH. The FT4 is not very bad. This is okay. So most common cause of this patient is why you're having is due to thyrotoxicosis. Is it a thyroid storm which is happening? Or is it because of steroid-induced TS suppression? Not thyroid. So we must remember that if you have a patient who's sick, who's having asthma or having any other illness or is fever and this, try to avoid doing thyroid function during that because you will have false low TSH, you may have a different picture of the T4 also, and this is all because of non-thyroid illness. In non-thyroid illness, you can have these pictures. So in this case, it's a non-thyroid or a steroid induced because he got steroids also, winning methylprednisolone. So it may cause steroid induced TS suppression. That's why you have this picture. So giving to the answer would be this is steroid-induced TS suppression and or ninth ordinance. So TSH is low in ninth ordinance and inhibited by drugs such as PTU, dexamethasone, amiodarone, and propranolol. So that is, it's advisable not to do TAF in a sick child or a sick adolescent. So you will get a false low TSH. Another case, interesting case, a 16-year-old girl with irregular cycles. She has 5 cycles a year, visited gynecologist and was diagnosed with PCOD. So she went to the gynecologist as usual and a 16-year-old girl, irregular cycle, oh, you must be having PCOD. PCOD हो गया तुमको तो polycystic ovarian disease हो गया और ये polycystic ovarian syndrome और PCOS हो गया. So this is there. The BMI was 29. So she was a little overweight. Normal BMI is between 23 to 23, less than 23 is good, and 23, 27 is just over. So this is obese. So she was managed lifestyle management, lot of lifestyle management, OCPs and metformin for a year. So she was managed lifestyle management, oral contraceptive pills, and metformin for a year. She was referred for weight gain. He was referred because of weight gain. Did thyroid function test. T4 was 8.4, T3 was 165, TSH 8.2. What is the cause and diagnosis? So what do you find in this patient? You find that the T4 is 8.4, T3 is 165, TSH is 8.2. So this looks to be, TSH is high and T3 is also a little, it's on the higher side. T4 is okay because this is in micrograms. So this is basically, there is increase in TSH with normal T4 and T3. So this is called a subclinical hypothyroidism because this girl was given, she was given OC pills. OC pills contain estrogen. So estrogen will cause increase in thyroxine binding globin. When thyroxine binding globin, the T4 and T3 will become less. So then the TSH will increase. So therefore, this is basically because of increased TBG. So altered thyroid function because of oral contraceptive factor increased TBG. So FT3 and FT3 should be done instead of total T4 and T3, especially in such patient if you're getting your picture where you are a patient taking some medicine or something which is causing some change in the thyroxine binding globin. So there, oh sorry. So another case, this is an 18-year-old boy He's a known hypothyroid on thyroxine, 50 microgram. The FT4 is 1.23, TSH is 3.6. This is normal. One episode he had a grand, grand convulsive seizure. So GTS seizures. So one convulsive seizure, grand mal seizure. And EEG was showing cerebral dysrhythmia. Started anticonvulsant, steroid, and albendazole. 4 months later, his FT4 was 0.79, the TSH was 8 point cause. So, what was the cause of this? Why did he get his hypothyroidism? So, the cause is what is happening is in that in this patient is getting some drugs which causes increased metabolism of T4 and FT4 and T4. As a result of it, there is increase in TSH and decrease in T4 and T4. So, this is because of the drug induced hypothyroidism. So 20 to 40% of this decrease of T4 and T4 because of drugs causing increased hepatic metabolism, phenobarbital. So this drug causes increased metabolism like phenobarbital. So that is why we had, in this case, there is an enzyme cytochrome 450 which is gets induced by phenobarbital and causes metabolism more of T4 and T3. So that is why you're getting a less T4, therefore more of TSH. So this is basically a drug-induced hypothyroidism. Oh, another interesting case 34 weeks, male which is delivered to a 25-year mother on levothyroxine hypothyroid. So this mother was on thyroxine because she had hypothyroid, so she was taking thyroxine. When the baby was seen at 34 delivered, hepatosplenomegaly, large liver and spleen, tachypnea is there, there's tachycardia there, there's thrombocytopenia, leukocytosis, NICU for respiratory distress and possible sepsis. So admitted in the NICU for this. When further lab was done, it was found that there was increase in bilirubin levels, elevated liver enzyme, there was increase in ammonia levels, an echoguard showed tricuspid regurgitation. A goiter is seen on the fourth day of age. So there's a goiter which was seen on the fourth day of age. The baby is referred to a pediatric endocrinologist who sees that goiter and starts taking history for the mother. And mother comes with history that she had taken radiation. So she had taken some treatment for thyroid with the help of radiotherapy, and then that caused it. So there was a hypothyroidism after that. So she may be a case of Graves' disease or maybe a case of this, and she had maybe the antibodies still in the body, and those antibodies crossed over to the baby and they caused what it caused neonatal. So maybe the baby had this. So the maternal history of radiolation for Graves' disease 2 years earlier. The thyroid function test in the baby showed T4 of 11.2 TSS low. So what is the next step in management? The next step is wait and watch, propanol, surgery. So we like to start the treatment because we know that we already have now a case who's having all the symptoms and it's basically a typical case of neonatal thyrotoxicosis because of antibodies going and stimulating this. So propanol and antithyroid therapy. So antithyroid therapy methimazole. So active agents affected hypothyroidism. Propanol is there. What is the action? Suppression of sympathetic pictures. So 1 to 2 milligram per kg per day. Then PTO is also there. Propyl thiazide. Decrease T4 and T3 conversion. So 5 to 10 milligram per kg. Methimazole prevents T4 and T3 synthesis. Okay, you can't synthesize that. So therefore inhibits peroxidase and iodination. And the dose is zero point 0.2 to zero point 0.5 milligram per kg per day. That is there. So and then prednisone, decrease T4 and T3 conversion, 1 to 2 milligram per kg per day. So sodium ipodate, decrease T4. They both everybody is acting to decrease T4 conversion at the periphery also. So 100 milligram per day. So basically these prednisone, sodium ipodate, they are more used in the thyroid crisis than the general. So therefore these all agents are effective in hypothyroidism. So you have sodium ipodate, you have prednisone, you have methimazole, propylthiazole, and propofol. So in this patient, propofol and antithyroid medication was started. Another interesting case: a 7 days old male baby, born and turned by normal vaginal delivery, coming to do from mother bringing the complaints and not gaining weight, very irritable the child, always hungry, hungry, irritable, lying down in the bed. Whenever I feed, he's always sucking my breast. I know that there is too much irritable, always crying and passing stool. So birth weight was 2.9 kgs and length was 49. Mother had history of Graves' disease, but she never took treatment for Graves' disease. and she had TSH receptor antibody positive. And the best part is there nobody done screening for this baby. Neonatal screening for hypothyroidism was not done for this baby. So just 7 days came back with this, not getting an irritability. So on examination, the weight was 2,600 grams. Weight loss had occurred in this baby. Look very much malnourished, hyperexcitable, heart rate 170 a minute, BP was normal. So look was very malnourished, hyperexcitable, heart rate 170 a minute, BP was normal. So this showed that there's a lot of tachycardia, there's like movements, tremor, nervousness, that's all happening. So lab evaluation showed that TS is less than 0.001, T4 was raised 6 nanograms, TR receptor antibody were positive, echo was normal. So this showed that this is more likely in case of neonatal thyrotoxicosis. Baby born having tachycardia, hepatitis B, sepsis like picture. He's also having a lot of finding in the heart tachycardia tachycardia. So further on, when you see the baby, there's a history of the mother having either hypothyroid, mother having grave disease, mother having medicine taken, but history must be taken properly because that is a receptor antibody gone. So this will cause neonatal thyrotoxicosis. It's normally a self-limiting disease, and with time, it will most of these patients will become fine. Oh, another case, this one is a case of thyroid nodule, and a 13-year-old girl was seen in the pediatric endocrinology hospital because of an enlarging neck mass. So she had come to the pediatric endocrinology clinic because of enlarging neck mass. Before 8 days earlier, the patient only noticed swelling of the neck and pain on swallowing. So she was complaining when I swallow, I have pain. 2 days later, her pediatrician noted the patient had an enlarged thyroid gland. So he said, you have to get some lab tests done. So lab tests were done, and it showed serum thyroid. That means TSH was 5.59. The normal range is 0.28 to 3.89. Free thyroxine. So that means your FT4, or you can say that zero point 0.8 nanogram, reference 0.5 is normal. Then your T3 FT3 is within range 87 to 178. So basically the anti-thyroid antibodies are positive 244, and anti-thyroglobulin antibodies level is greater than 3000. So therefore these positive thyroid antibodies with a TSH high, with a hypogoiter like enlarged neck mass, this shows that we must start treating this something happen. So the complete blood electrolyte was normal. Patient came to endocrinologist after 5 days, where she was seen 5 days later. The presenting symptom, patient reported tightness in her neck. So there was a lot of tightness in the neck and occasional nausea, but no difficulty in swallowing or breathing. So therefore, this is nothing. That means not pressing on the esophagus or on the trachea. So she did not have any sensation of feeling hot, cold. There was no change in weight. There was no change in appetite. There was no change in degree of thirst. There was no change in level, energy level, skin, palpitation, diarrhea, constipation, abdominal pain, vomiting, skin lesion. All this was okay. So patient was born after full-term gestation without complication. The only thing is that menarche in this 13-year-old girl occurred at the age of 9 years. So when menarche occurred at the age of 9 years, her menstrual cycle was totally irregular. But now by they started to become regular and lasting around 3 to 5 days, which is normal. Her the maternal grandmother, the maternal aunt and cousins, all were patients of hypothyroidism. So now there are two things in this child. This baby has got this child has got high TSH, low FT4. So it's going to a hypothyroid picture, but beyond that, it has a nodule also. So there, this nodule was present on one side was a concern. So what are the causes of thyroid nodule? Normally, a benign is more than 90% of the time it is benign, and malignant is all 6% of the time. So multinodal goiter, colloid adenoma, Hashimoto's cause of the one of the cause of the thyroid nodule is Hashimoto's thyroiditis, chronic lymphocytic thyroiditis. Cysts are there, so maybe a colloid cyst, maybe a simple cyst, and maybe a hemorrhagic cyst. The 70 to 14% hemorrhagic cyst can be malignant. Most commonly, the malignant is papillary carcinoma with the cystic component with the most increased size 2 to 4 centimeters. Then there is follicular adenoma. Follicular, there may be a macrofollicular, maybe microfollicular adenoma. And then there is a oxyphal adenomas. These very macro, micro, not microfollicular. So therefore, these are benign ones. So as for you to remember, you must remember that most common is benign. But if you do get a nodule in a pediatric or other, you must work it up properly before it is saying it's benign, because whatever is malignancy can be more commonly seen in the pediatric, whatever the person their nodule you find. So malignant about 6%, papillary, follicular, minimal and widely invasive oxyphilic type, medullary, malignant, anaplastic, memory, prior lymphoma, metastatic carcinoma, all these other. So you will have benign versus malignant. Now, what are historical red flags when you start thinking of looking at a nodule? Is this recent growth? Has it been present over the last few years, few days? Any soft tissue swelling? Any vocal changes? Dysphagia, signs of thyroid dysfunction. So these are something one has to keep in mind, that there is recent growth, there's soft tissue swelling, vocal changes, there is dysphagia, there is signs of thyroid dysfunction. Are they there or not? Whether these things are there or not? If they are there, how do we proceed further? So you have to keep a watch on the esophagus or the trachea, and you have to see other thyroid dysfunction, soft tissue swelling. So now, no, there's a very nice chart. We just tell you if a patient comes with thyroid nodule, check the TSH first. अगर TSH low है और TSH normal है, अगर TSH low है, do a scan. Do a radioactive scan. When you do a, if you find a hot nodule, that nodule is hot, just observe. If you find T4, T everything is raised, treat it as overt hypothyroidism, and you can treat it and then see what's happening. Now, if you have TSH is normal, then do a FNA and fix, do a final aspiration, see what's happening. So if the TSH is normal as high nodule, so 70% of these are benign and you just need observation. 5% of these may be malignant and surgery may be required. And in 15% there is non-diagnostic. You don't know what's there. So just repeat FNA or ultrasound FNA, try to do again. Maybe do not pick up that area, maybe that area was different. And 10% indeterminate. So do a scan in that and see what's happening. And do a indeterminate performance expression scan and see what's happening. So this is how you should approach a patient of thyroid nodule. So most important, remember, benign is more common as compared to malignant. And once the TSH is low, you start thinking of your grave disease or hyperthyroid. Now, in our case, which we just saw, the differential diagnosis will be goiter, so just a pure goiter, thyroiditis, thyroid nodule, and thyroid cancers. So coming back to the case, the ultrasound was done of this child, and they found that there was a bilateral thyroid enlargement with microcalcification throughout the gland. So the whole gland there were microcalcifications. So this was there. And they were large enlarged nodes, bilateral, low in the neck as well as lymph node bilateral along both jugular veins. So this made some suspicion after seeing an ultrasound, a lot of lymph nodes along the jugular vein and then along with the the neck area. So then they thought that this patient needs some operation. So the operative procedure would be the bilateral central, remove all the nodes, and bilateral modified radical neck dissection were performed. So I don't know, diagnosis papillary thyroid carcinoma, diffuse sclerosing variant, acute chronic. This was there. This was a finally diagnosed with chronic autoimmune thyroiditis. So operative management of the case. Now there is a lot of controversy regarding the surgical treatment of papillary thyroid carcinoma, which are very small, very have low recurrence. So the American Thyroid recommend that you do a surgery in those patients which are larger than 1 to 1.5 centimeters. So do a total thyroidectomy in them. So the trend in USA is, especially with patients with pelvic thyroid, is to undergo total thyroidectomy. Now in this patient, you need to do a total thyroidectomy because it's a diffuse disease we found, and microplastic is present all over the thyroid tissue. and there were a lot of nodal. See, I told you a lot of nodal lymph nodes was there. So, so in when you want to evaluate a nodule, solitary nodule evaluation, if the TSH is low, scan. It's very, very helpful if the TSH is low. Scan. If hot nodule, observe what's happening, what's going on. Is it because it's maybe just because of hypothyroid? It's a autonomous nodule is producing excess amount of thyroxine. If the normal TSH is there, that means TSH is not, but it's normal. So the question comes: do I scan first or do I FNA? So if there's a high risk, if you feel that there's a high risk, there's a family history of peptic carcinoma, there's some histories available, the size is very big, looks to be 2 centimeters, 3 centimeters, then you have a high risk to do a scan and an FNA together. So if this is nodule is cold or hot, according to the scan, you come to know. If it is cold, you must do a FNA biopsy, not FNAC. So biopsy must be done. So if a low risk, then do a final aspiration. That's all. But if you have a high risk, better to do it. Scan an FNA, and after doing FNA, you find it's cold, do a biopsy, move it. Indeterminate scan and FNA or like excisional biopsy must be done when you have indeterminate nodulism. So TPO sometimes helps because if it is low, and if antithyroxine sometimes anti help because if there is low TSH to diagnose thyroiditis. So what you can do, you have a high TPO with low TSH, it's going to be easy to diagnose thyroiditis. So never assume a solitary thyroid nodule is benign. Prove it that it is benign if you say it's benign, especially in the pediatric and adolescent population. So thank you very much for everyone for your kind attention. And this is the website www.ipscoacher.com where you can get all lot of things on endocrinology, question answers. There are a lot of there is a lot of videos and there a lot of explanation on many facts like thyroid, diabetes, about everything. A lot of things are there. You can get a lot of information. So thank you very much. Back to you, Nishita.
Thank you so much, sir. You presented the case so well, and it was really interesting as well. So, with your due permission, shall we move forward to our question answer round?
Yeah, yeah, sure, sure.
Thank you so much, sir. Now, I would like to request all the participating doctors, if you have any queries regarding the session, please feel free to paste it in the comment section so that I can put forward it to sir. So, we already received questions. First question is by Dr. Sujata Mukherjee. Doctor wants to know what is the cutoff level of T3, FT4, TSH level for children to start medicine for hypothyroidism.
For hyper.
Hypothyroidism.
Hypothyroidism, okay. See, remember the basic fundamental rule. If the TSH is more than 20, less than 2 weeks old baby, then you should have think that there is something wrong. You may need to evaluate this child more. If the TSH is more than 10 after 2 weeks of a baby born, after 2 weeks of age, then this child will need to be evaluated. Most probably need hypertension. So just call him back and do the sampling. If the child crosses after any time after 2 weeks till 10 months, till 2 years, till 3 years, 4 years, TSH more than 10, it means you need to have this is not something, this is hypothyroidism. So you need to treat this patient, follow them up. Many of them will become okay, many of them they're not okay. And so therefore the cutoff will be TSH more than 20, less than 2 weeks of age, and TSH more than 10 above 2 weeks of age. T4 and T4 is there. T4, if you're doing a free T4 and a total T4, total two different things. So if you have a T4, a free T4 of less than 1.1, you should think that this patient is having hypothyroidism. And if you have this T3 has nothing. There's nothing to be done with T3 as far as hypothyroidism. It's more relevant in hyperthyroidism. So if you do a plain T4 and TSH only or a FT4 and TSH, that is enough to pick up diagnose hypothyroidism. So if you have many time, you pick up many time cases will come to you at 7 years, 8 years, 12 years, 16 years. They come with T4 is normal, TSH is 7, TSH is 6, TSH is 8. So that does not mean you need to treat them. This is called subclinical hypertension. So wait and watch and keep on doing repeat after 2 months. Again FT4 TSH. Till the TSH crosses 10, you're not supposed to treat them. Only after TSH, it crosses 10, you should treat this patient. So that is why after 2 weeks of age till any age, this is the way you should manage this.
Thank you so much, sir. So next we receive a case from Dr. Prince Kumar. Doctor has written 20 to 30 years
Where is
old.
Dr. Prince Kumar from which place?
Uh, s- so doctor hasn't mentioned his
Okay,
place.
anyway, no problem. Okay.
Okay. Sir, the doctor has written 20 to 30 years old patient with Hashimoto thyroiditis presenting with neck swelling, TSH 150 per milliliter, T3, T4 is normal range, and USG showing B slash L, enlarged thyroid with coarse echo texture and increased vascularity. What is the approach in this patient? What is steroid role in this?
There is no role of steroid. Steroid is zero role. So this is basically a patient who has got, the thyroid tissue is production is more. So TS is more being produced by thyroid because of, so TS is coming more from the pituitary, causing the thyroid to function more and more, trying to burn more thyroxine and maintaining T4 T3. So in these patients who has a high TSH more than 150 NSA, and when you did an ultrasound showed a higher vascular, thyroid tissue with uptake this thing. So these just tells us that the thyroid is trying to function more and more and more and more in order to produce T4 and T3. So later on, what happens in initial phases, it maintains. Then it fails. So then T4 and T3 start falling and TSS rise more. So what in this case, we will have to start with a low dose, 20, 30 years old patient. Start with a low dose of, thyroxine, maybe 25, and then gradually increase to 50 over 3, 4 weeks, and gradually keep on monitoring till you bring the TSH back to normal, and the T4 is already normal. So keep on monitoring till you bring the TSH back to normal. Start with a low dose and gradually build it up.
Thank you so much, sir. I would again like to request all our participating doctors if they have any queries regarding the session, please feel free to paste it in the comment section so that sir can give all of your queries answer. So the next question we received from Dr. Shankar Khalko. Doctor wants to know way to diagnose thyroid myopathy and cardiomyopathy.
So thyroid cardiomyopathy is totally different. Cardiomyopathy, there are many causes for cardiomyopathy. And when you talk about thyroid myopathy is related to thyroid tissue, commonly seen in patients who are having, you can get it even in hypothyroidism. Long-term hypothyroidism will cause some amount of myopathy. The muscles, especially the proximal muscles, they become weak, and their energy become. Cardiomyopathy is basically when you do a, the cardiac, when you do an echo, you'll find that finding of cardiom. So the cause may be, most probably maybe in hyperthyroidism instead of hypothyroidism, but you can get even in hypothyroidism some cases of cardiomyopathy. And then these are beside this, you might find many other causes of cardiomyopathy, which may be there because there's so many other causes may be there which can cause. But when you cause with thyroid myopathy means involvement of the muscles because of a thyroid tissue, whether it is hyper or hypo. So hypo, you will get myopathy. Hyper also there is long term. You can get myopathies very easily. So therefore, depending upon what you're having, you treat that patient with the medicines. Whether if it is hypo, you treat them with thyroxine. But if it is hyper, you treat them with neomercazole or you treat them with methimazole, and then bring back the thyroid function back to normal. So this is what is there in myopathy.
Thank you so much, sir. Um Next question is by Dr. Chetna Bansal. Doctor wants to know if TSH is normal and anti-TPO is positive, then also patient would need TT. Your comments, sir, on this.
The patient need what?
Doctor has written TT.
TT. Okay,
Yes.
okay. TT means thyroxine treatment. No, this patient will not need thyroxine treatment. So if a TPO is raised, TSH is normal, no, it will not need treatment. You have to follow up these patients. Maybe this patient is going into subclinical hypothyroidism and may become overt hypothyroidism in the future. So these patients do not need treatment. They do not treatment because you have to wait and watch and see what's happening in the future. So maybe this patient who is having a high TPO because TPO antibody may be present for other without any hypothyroidism also. You may find in a normal population also. So that does not mean you need to treat. So TPO raised with normal TSH, no need to start treatment. There's no need for treatment.
Thank you so much, sir, answering all the questions so very well. Again, I would like to request all the participating doctors, if you have any more questions left with you, please paste it in the comment section so that Dr. Kocher can give all of your answer. Doctors, please be hurry and please paste your question in the comment section. Sir,
Yeah.
your video is off. Can you please turn on?
Okay.
Yeah, right now. So we again received one more question.
Yeah, yeah.
Question is by Dr. Sangeeta. Doctor wants to know, do we need to get routine TSH done at the age of puberty? Any guidelines? And along with that, doctor also has written when to perform and what age the landmark apart from the pregnancy in adults.
There is no guidelines for doing TSH in puberty. There is no program like this to do TSH in puberty, because even there is no program, universal program till yet to do TSH in in pregnancy also. Although we are all doing it now, we trying to motivate people that there must be a universal program for newborn screening. There must be a universal program for in pregnancy to pick up this third, and then because there are a lot of problem issue will come during the pregnancy there. But in puberty, there are no guidelines to do TSH. People are doing TSH in puberty because they find some findings of their TSH coming out. But I think one has to, if you find a puberty goiter is there, or you find the paper, the girl or the boy is having growth problem, or you find the girl or boy has symptoms suggestive of hyperthyroidism, you might do a TSH. Otherwise, there is no guidance or there is no indication for doing a TSH in puberty as a screening program.
Thank you so much, sir, for answering. Uh, Sir, as of now, we don't receive any more questions. So I would like to thank you, sir, for giving us time from your busy schedule, and you presented a beautiful case presentation along with your experience on this. And I hope definitely it will help our participating doctors in their practical uses. I also want to thank all our participating doctors for joining today's session. Thank you so much, everyone, and thank you so much, sir. So, with your due permission, shall I conclude the session here now for today?
Yeah, yeah, we can. If there are no questions further, we can conclude it.
Yes, sir, there are no more questions.
Okay. Okay. Thank
Thank
you
you
very
so much.
much, everyone, yeah, for joining in. Thank you, Nishita.
Thank you so much, sir. Have a great day ahead.
Thank you. Thank you very much. Thank you.